Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination here at the Task Force for Global Health in Atlanta, Georgia, USA. It's great to be able to welcome all of you to the 65th edition of our webinar series, where we look at different aspects of hepatitis prevention, diagnosis, care, and treatment. Today, we're going to be exploring the role of quantitative hepatitis B surface antigen testing to guide hepatitis B treatment in the U.S. with a global perspective. Greatly appreciate all the speakers that you'll be hearing from here over the next 90 minutes. Next slide, please. As you listen to the presentations, please submit your questions to the Q&A function on at the bottom of your screen. For questions that just on different aspects, we'll try our best to ask the speakers to respond to those directly in the Q&A, and then for the discussion period, pull out those that are more cross-cutting. The webinars are all recorded and they're all posted on our website at globalhep.org, along with all the slide presentations. So encourage you to look at to use those as information resources going forward, and they're particularly helpful for those that aren't able to connect with us live. And while you're there, you can sign up for our newsletter, where you can be informed of webinars and other activities of the coalition in the future. Next slide, please. As I mentioned, we have a rich webinar series. So when you go to the webinar page on our website, you'll be able to see all of those all of that information that's there and that you may want to explore. Thank you. Next slide. So let's go ahead and get started. As you'll see here, we have several presentations looking at different aspects of quantitative hepatitis B surface antigen testing, perspectives from Asia, from Europe, and here in the United States, where they'll be having presentations from commercial laboratories and how they make this test available, and then a presentation on an evaluation of test quality for hepatitis B surface antigen, and then we will have a discussion period. So it's as you can see, we have a great group of speakers, and so let's get started. If we can have the next slide, please. Thank you. I'll turn it over to our colleague, Dr. Young-Suk Lim, who's professor of the Department of Gastroenterology at Asan Medical Center at University of Ulsan College of Medicine in Seoul, Korea. He's also president of the Korean Association for Study of the Liver. Dr. Lim, over to you.
Thank you, John, for very kindly introducing me. Would you allow me to share my slides? Okay. Okay. Good evening. It's my real pleasure to be here with you. Over the next 15 minutes, I'd like to give you a global perspective on quantitative HBs antigen testing. I'm coming at this from South Korea as the president of the Korean Association for the Study of the Liver. And we have many HBV infected patients because of the high prevalence in Korea. And so I hope the view of our side of the world is useful as you think about practice here in the United States. So conventional biomarkers for HBV infection includes qualitative HBs antigen testing, HBe antigen, and HBV DNA. These tests we have all relied on for decades. Among the new biomarkers, quantitative HBs antigen is now fully established because unlike the others, like HBV RNA, correlated antigen, the quantitative HBs antigen is standardized, widely available, and is being used in the clinic today. HBs antigen is produced from two sources, covalently closed circular DNA, cccDNA, and HBV DNA that has integrated into the host genome. In HBe antigen negative patients, HBs antigen production is largely driven by that integrated DNA, not by cccDNA. So in those patients, the HBs antigen level is telling us as much about integration as it is about active viral replication. But this slide makes the same point with the data. The question is whether HBs antigen is a good surrogate for transcriptionally active cccDNA. In e antigen positive patients, there is a reasonable good correlation between serum HBs antigen levels and the cccDNA in the liver. But in e antigen negative patients, on the right side panel, the relationship is not there, with no good correlation between serum HBs antigen levels and the cccDNA in the liver. So integrations are the major source of HBs antigen, e antigen negative patients. There is some mechanism in animal data in the e antigen positive status. Only about 1% of the messenger RNA making HBs antigen comes from integrated DNA. But after the transition to e antigen negative, more than 60% comes from the integration. And the long read RNA sequencing in humans tells the same story as like the animal study. And this has a direct clinical consequence. When we treat patients with nucleoside or nucleotide analogues, circulating HBV DNA decrease very fast. And then cccDNA slowly it declines also, but HBs antigen very decreases. This is because a lot of the HBs antigen is being transcribed from integrated DNA, and antivirals which target replication don't touch it, that source. That's why HBs antigen is so stable on oral antiviral therapy. HBs antigen decline to the undetectable level, therefore, means we have successfully suppressed the antigen production from both sources. This is a conceptual basis for that HBs antigen loss is the definition of a functional cure, and further, complete cure or sterilizing cure. Identifying patients at higher risk of disease progression, such as cirrhosis and HCC, is one of the potential application of quantitative HBs antigen testing. And also predicting relapse after stopping nucleoside or nucleotide analogues. And more importantly, predicting response to the novel therapies coming through the pipeline would be the major applications of quantitative HBs antigen testing. On the right side, there might be some limitations of quantitative HBs antigen testing, but these may not be the limitations, but just the points we have to do considering the interpretation of the results. So among the markers to predict future HBs antigen loss, quantitative S antigen has the highest value, which was higher than other biomarkers such as correlated antigen or HBV RNA. In this post-hoc analysis, baseline quantitative S antigen gave an AURC value of about 0.92, which is very high, well above correlated antigen of 0.65 and HBV RNA of 0.54. And on treatment, S antigen decline greater than 3.5 logs predicted seroclearance of HBs antigen in a high sensitivity and specificity. So as a surrogate for future functional cure, quantitative S antigen is the best of the predictive biomarkers. With our standard of care therapies currently available, only a minority of the patients actually achieve HBs antigen seroclearance or functional cure. But this is the encouraging part. When they do achieve it, it's durable in the vast majority of the patients, whether the HBs antigen seroclearance was achieved spontaneously or by oral antiviral therapy. In this Hong Kong study, compared to the patients with complete HBV DNA suppression by antivirals, those who also lost HBs antigen had 76% further decline in HCC instance. So undetectable HBV DNA is good, but the undetectable HBs antigen is better. This systematic review and meta-analysis confirms it across the studies. HBs antigen seroclearance was associated with significant reductions in the risk of hepatic decompensation, HCC, transplant or death, and the first clinical event, reductions on the range of 70% or 78%. This was observed consistently across all of the strata, including spontaneous or treatment-induced HBs antigen seroclearance. Even without full clearance of HBs antigen, may benefit. In these long-term Taiwanese cohorts of patients with inactive hepatitis, those with HBs antigen below 100 had an annual HCC instance, the lowest of just about 0.08%, extremely low. So as the patients had lower HBs antigen level, they had the lower risk to develop HCC. Pulling six studies make the same point quantitatively. Patients with HBs antigen above 100 IU had about a 5-fold higher risk to develop HCC than those below 100, which reinforces 100 IU per ml as a meaningful threshold. Now moving on to stopping therapy, the rate of HBs antigen seroclearance after stopping NA varies significantly by ethnicity and HBs antigen level at discontinuation. In this RETRACT-B study data, white patients with end of treatment HBs antigen under 1,000 had a 41% chance of HBs antigen loss versus only 5% above that. In Asian patients, the threshold was lower. Under 100, gave 33% versus 2% with 100 above. Again, now over 1,500 patients, quantitative S antigen at the time of stopping the treatment predicts both the good outcome, HBs antigen loss, and the flare we worry about. So the same number help us pick who's likely to clear HBs antigen and warns us who needs close monitoring after withdrawal or who should not discontinue the treatment. Now let's look forward to novel therapies. This is where HBs antigen quantitation really has its value. These are the phase 3 BeWare trials with bepirovirsen, an antisense oligonucleotide ASO in virologically suppressed patients. Based on the findings from the preceding phase 2 trials, only the patients with HBs antigen between 100 and 3,000 were enrolled in these two phase 3 trials, and the patients were stratified by their HBs antigen level at the beginning. Functional cure with bepirovirsen was strongly dependent on baseline HBs antigen. In patients starting at or below 3,000, the cure rate was about 19%, but in those at or below 1,000, it rose to 26% versus 0% on placebo in both studies. So the lower the starting HBs antigen, the better the response to the new drug. The biomarker predicts who benefits. This forest plot confirms it across subgroups. The treatment effect, the risk difference versus placebo was consistently larger in patients with baseline S antigen under 1,000 than those above it in both BEWARE 1 and 2 studies. So baseline S antigen is just prognostic, but it's also predictive of who responds to therapy. So in choosing patients for the treatment with novel agents, the information for HBs antigen level is very essential. Current standard assays for HBs antigen have lower limit of detection 0.05 IU per ml. However, newer ultrasensitive assays go down much further. Abbott's next to 0.005 and Fujifilm Bio ITACT down to 0.0005, 10 to 100 times more sensitive. However, data are limited for the clinical usefulness of these ultrasensitive S antigen tests. So in summary, in HBe antigen negative patients, S antigen production is largely driven by integrated HBV DNA, not by cccDNA. S antigen loss is very stable off-treatment standard endpoint for NA therapy. HBs antigen loss is associated with very favorable outcomes, less cirrhosis, very low instance of HCC and mortality. However, detectable but low HBs antigen titer below 100 IU has favorable outcomes, low relapse rate, and flare risk after stopping NA. The good predictor of functional cure with novel anti-HBV therapies is the HBs antigen test, which is very essential test for patients' selection for the novel therapies. So I believe that quantitative HBs antigen test should be routinely measured to guide treatment decisions and inform prognosis. Thank you very much for your kind attention.
Thank you very much for your excellent presentation. We greatly appreciate it. Very comprehensive. Before we transition to Maria, Dr. Budi, could you just briefly touch on what are the recommendations for hepatitis B treatment in Korea, and how is the quantitative hepatitis B surface antigen testing included in those treatment recommendations, please?
Yes, in South Korea, the clinical practice guidelines recommend to use quantitative HBs antigen before deciding to discontinue or not current nuke or NA therapies. It's a very, very strong recommendation. And if the patients have HBs antigen levels above 100 IU per ml, the guidelines do not recommend discontinuing the treatment. And also, for the upcoming new novel therapies for HBV infection, we will update our guidelines to recommend the HBs antigen levels in selecting the proper patients for the new novel therapies. Thank you.
Thank you very much. please put other questions in the Q&A function, and we'll do our best to answer them along the way and then bring them in front of the panel at the end of our webinar today. Let me now turn it over to our colleague, Dr. Maria Budi, who to give us an update from the European perspective, as well as her own clinical experience regarding the role of quantitative hepatitis B surface antigen testing in clinical management and the emerging functional cure strategies. Maria is a professor of medicine and consultant of hepatology at University Hospital Vall d'Hebron in Barcelona. Maria, over to you, please.
Thank you, John. Thank you for the invitation. It's really a pleasure to be here today. Good afternoon, good morning, and good evening. My task today is to discuss the role of HBs antigen in Europe, and I can tell you that in the majority of academic centers across the European Union have available HBs antigen quantitative in their labs. We use HBs antigen levels to determine the different phases of the infection, to define partial cure and predict functional cure, to monitoring HBV infection and treatment response, and regarding the new treatments, particularly to assess candidates for these new drugs. Let's start with the natural history of HBV and treatment indications, and these are the EASL guidelines. EASL guidelines recommend the use of quantitative HBs antigen to help to determine the stage of the infection. E antigen positive chronic infection that are immune tolerant patients are those with the higher levels, then the levels decline in those with chronic hepatitis, and even lower in E-negative chronic infection, inactive carriers, or E-negative chronic hepatitis. And this is based in several studies that show that there is a decline in HBs antigen levels, particularly in E-negative patients where there is some degree of immune control, and in a way that HBs antigen levels can translate the rate of immune control. This is a landmark study performed by Mauricio Brunetto in Europe and confirmed in other studies that the combination of HBs antigen levels below 1,000 international units per ml plus HBV DNA levels below 2,000 identify inactive carriers. Only using HBs antigen and HBV DNA, it's possible to identify inactive carriers in one determination without need of follow-up. And this is particularly true for genotype D patients. And the genotype B, is the most frequent genotype in European countries. The second point that I would like to discuss is the role to define or to predict functional cure. And there are several studies, and this is a meta-analysis of and a systematic review of different studies showing that in untreated patients with nucleoside analogues and also untreated patients, the rate of HBs antigen clearance is very, very low. But low levels of HBs antigen levels below or around 100 are those associated with a higher rate of HBs antigen clearance, as well as low baseline HBV DNA levels, particularly in E-negative patients. And 3 years ago, Mark Gani and another investigators, and in collaboration with regulatory agencies and with the industry, we defined the guidance on treatment endpoints for clinical trials aiming to achieve functional cure in chronic hepatitis B. And in addition to the definition of functional cure that everybody knows, HBs antigen loss of treatment, 24 weeks of any treatment plus undetectable HBV DNA, there is an intermediate or alternative endpoint that is partial cure. And partial cure is defined by HBs antigen levels below 100 with undetectable HBV RNA 24 weeks of treatment. With the current drugs and during the natural history, EASL guidelines recommend to monitoring HBs antigen should be tested to characterize disease phase, define prognosis, and treatment guide, as Professor Lim has shown, and the grade of this recommendation is strong. And in addition to use as a diagnostic test, levels of HBs antigen should be determined every 12 months. And if this is not possible, a quantitative determination, the recommendation then is to do annually a qualitative HBs antigen test. If you look at patients treated with tenofovir, the rate of HBs antigen clearance, and this is long-term treatment with tenofovir, is very, very low. Oral nucleosides are very potent suppressing viral replication, but have minimal chance of functional cure. These are data on long-term viral suppressed chronic hepatitis B patients, so that there are patients treated with tenofovir for more than 8 years, and you can see that only less than 20% achieve HBs antigen levels below 100, the magic number associated with probably a better disease prognosis and a higher likelihood of HBs antigen loss. So you can see that the levels of HBs antigen are stable, and there is a decline, and the proportion of patients that reach these levels below 100 is relatively low. So for this reason, EASL guidelines recommend that quantitative HBs antigen levels should be determined every 12 months. And this can help to identify patients with a higher likelihood of HBs antigen clearance and better prognosis. Regarding interferon in Europe is practically nobody use interferon. There is an important role of HBs antigen quantitative, and it's particularly useful as a stopping rule for those patients who don't achieve a decline in HBs antigen levels at week 12 and week 24 of treatment. And finally, I would like to finish with assessment of candidates to new treatments. This is one of the first studies with SINRA, with an RNA interference in patients with chronic hepatitis B, and you can see dramatic declines in HBs antigen levels. The majority of patients achieve 75% achieve HBs antigen levels below 100 at week 48 of treatment, but none of these patients lost HBs antigen at the end of treatment and off treatment, and there is a rebound in HBs antigen levels. The second important study, and Professor Lim has shown, is with an antisense oligonucleotide. This is the phase 3 study with bepirovirsen in E-positive and E-negative patients. This patient received treatment for 24 weeks, and after treatment, off treatment, in both studies, in BWELL-1 and BWELL-2, that are two studies parallel with the same inclusion criteria, the rate of HBs antigen loss was 90%. And if you look at the proportion that achieve low levels of HBs antigen without HBs antigen clearance, approximately 30% of patients treated with bepirovirsen have levels below 100 international units per ml 1 year after ending of treatment, showing these antisense oligonucleoside interferes or silences the production of HBs antigen. So in summary, quantitative HBs antigen in Europe has moved from a research tool to a clinical biomarker. It's widely available across European academic, tertiary, and reference laboratories. We use standardized automated assays with a high performance and reproducibility. And for me, the most important message is that it complements HBV DNA by providing not only viral activity, antigen activity, and help to define disease status, and is increasingly used to guide clinical decision-making, assess treatment response, and evaluate novel therapeutics and curative strategies. So thank you very much.
Thank you very much for the excellent presentation. Now, there was an interesting question in the Q&A that I tried to answer with some references I was aware of. Was, what percent of persons that are hepatitis B surface antigen positive have a quantitation less than 3,000 international units? I didn't know if are those data available for Europe, Maria?
Yeah, several centers have evaluated in our patients the number of those with below 3,000. So it depends if you look at inactive carriers or patients with chronic hepatitis B. If you look at patients with liver disease, with chronic hepatitis B, in negative patients that are the majority of our patients, around 50–60% of them have levels below 3,000.
Okay. I'm sorry. What percent below 3,000? I'm sorry.
Between 50 and 60%.
Okay. Thank you. That was the estimate for the reference I was aware of. So thank you for confirming that. Thank you for the additional questions in the chat. In the Q&A, we'll seek to get those to them. But let's move on to hear from our colleague, Dr. Mark Ghani, who's with the liver disease branch at the National Institute of Diabetes, Digestive, and Kidney Diseases at the US NIH. It's great to have Mark on the program to give a US perspective. Mark, over to you.
Okay, if you go to the advanced 2 slides, please. Okay, so as I was saying, unlike Asia and Europe, qualitative surface antigen testing isn't as readily available in academic centers here in the US. There are, however, several laboratory-developed assays that are available that are listed here, and there are also commercial assays that are available for research use only in the US, but are widely available outside the US, and they're listed there. So currently, there are no FDA-cleared or approved assays in the US. Next slide, please. So as you've heard from other speakers, quantitative surface antigen testing has an important role to play in the management of chronic hepatitis B, particularly in identification of disease phase, as Dr. Bhuti mentioned, the inactive carrier phase, as well as the immune tolerant phase. It's important also for defining treatment endpoints, as Dr. Bhuti also mentioned, and in predicting clinical outcomes, particularly spontaneous surface antigen loss and HCC risk stratification. It's also valuable in the selection of candidates for stopping nucleoside analog therapy and for the selection of candidates for novel therapy, as you've heard. Next slide, please. So for this talk, I'm going to focus just on addressing 3 key areas on the utility of surface antigen testing, that is in HCC risk stratification, selection of candidates for stopping treatment, and selection of candidates for novel therapy. Next slide, please. So I'll begin first with the role of quantitative testing in HCC risk stratification. And this data you've actually seen before. This is a meta-analysis of 8 studies, including over 12,000 patients, which looked at the association of surface antigen levels and the development of liver cancer. And what you can see here is that a surface antigen level more than 1,000, and Professor Kim had showed you 100, but here I'm showing you 1,000, was associated with a 2.5-fold increase risk of HCC compared to those with a level less than 1,000. Next slide, please. This is data from the REVEAL study, and the REVEAL study was a population-based natural history cohort from Taiwan that was predominantly e antigen negative, about 85%. And some of you may recall that this is the study that, if you will, revealed the importance of hepatitis B viremia with the risk of progression to cirrhosis and development of liver cancer. The REVEAL study also showed the relationship between surface antigen level and subsequent risk of cancer. And that's shown in the right panel there. And you can see that higher levels of surface antigen were associated with an increased risk of developing liver cancer. A surface antigen level greater than 1,000, shown in the green bar, was associated with an almost 5.5-fold increased risk of liver cancer compared to a level less than 100, shown by the blue bar. However, in the figure on the left, you can see that DNA was a stronger predictor of liver cancer than surface antigen level. Next slide, please. So this is data also from another population-based cohort from Taiwan, demonstrating that higher surface antigen levels are associated with higher HCC risk. And you can see on the figure shown on the far left panel that patients with surface antigen levels between 1,000 and less than 10,000, that's labeled with the Roman numeral 4, had the highest risk of HCC. And in a receiver operating characteristic curve analysis shown on the far right panel, HBV DNA was shown to be a better predictor of HCC development than surface antigen levels. Next slide, please. Importantly, this study showed that changes in surface antigen level were associated with HCC risk over time. And patients with persistently low surface antigen levels, less than 1,000, shown by the dark blue bar, had the lowest risk of HCC. In comparison, those with persistently high surface antigen levels, more than 1,000, had the highest risk. Now, also, the direction of change also matters. And an increase in surface antigen greater than 1,000, shown by the orange bar, was associated with an increased risk of liver cancer, as opposed to a decline less than 1,000, shown by the green bar, is associated with a subsequent decline in risk of HCC. So these data highlight one example of how serial monitoring of surface antigen can be used clinically to help you manage patients. Next slide, please. Now, where surface antigen levels may perform better than DNA in HCC risk assessment is the population with low HBV DNA levels. And that's shown in the middle panel with the outline by the red box. In this patient population, a high surface antigen level greater than 1,000 was associated with a significantly higher risk of HCC compared to those with a level less than 1,000. It was an almost 14-fold higher risk of HCC. Notably, lower surface antigen levels, less than 100, shown in the left panel, or even less than 10, was not helpful in risk stratification for HCC development. Similarly, a high surface antigen level was not helpful in HCC risk stratification among persons with levels greater than 2,000, and that's shown in the far right panel. So these findings highlight the value of surface antigen as being a complementary biomarker to HBV DNA, particularly in patients with low viremia, where DNA levels alone may not fully capture the HCC risk. Next slide, please. So this slide summarizes some useful surface antigen cutoff values that are helpful in management of untreated patients. And I put this up here really for the clinicians. So among e antigen positive persons, a level greater than 10 to the 5 in combination with a HBV DNA level greater than 10 to the 7 is highly suggestive of the immune tolerant phase. Among e antigen negative persons, a level less than 1,000 in combination with a HBV DNA less than 2,000 is very suggestive of inactive disease. And this is some data that Dr. Booty showed with you. And levels less than 100 are also highly predictive of subsequent surface antigen clearance. And Dr. Booty also showed some data to support this statement. And then finally, levels greater than 1,000 may help risk stratification of HCC in persons with DNA levels less than 2,000, as I've recently discussed. Next slide, please. So now I'll turn to the utility of surface antigen for selecting candidates for nucleoside analog withdrawal. And this data you've seen from Professor Lim. This is data from the RETRACT study. And this was a large multinational cohort of over 1,500 patients who were surface antigen positive and were withdrawn from nucleoside analog therapy. The cumulative rate of surface antigen loss in this cohort was 3.2% at 12 months and rose to 13% at 48 months. But there were several important findings that emerged from this study. The first was that race was an important determinant in terms of surface antigen loss. And the second was that the level of surface antigen was also an important determinant in predicting surface antigen loss. So if you follow the figure on the right side, among white persons with a surface antigen level less than 1,000 IU per mil, the rate of surface antigen loss was 41%. Contrast this with a value of only 5% among white persons with a level greater than 1,000. Similarly, among Asian patients, the cutoff of predicting surface antigen loss was tenfold lower, 100. At this level, 33% of patients experienced surface antigen loss compared to only 2% in those with surface antigen levels greater than 100. So the key point here again is that surface antigen levels are an important clinical determinant in selection of patients for stopping therapy, and the cutoff value for stopping therapy also varies by race, being 1,000 for persons who are white and 100 for persons who are Asian. Next slide, please. And these findings were subsequently confirmed in a meta-analysis, which showed that both race and end of treatment surface antigen levels were strong predictors of surface antigen loss after stopping treatment. If you follow on the left panel, using an end of treatment cutoff of 100, the pooled probability of surface antigen loss was 42% compared to 5% in those with levels greater than 100. Using a less stringent cutoff of 1,000, the findings were similar. The overall surface antigen loss rate was 22% in those less than 1,000 and only 3% in those with levels greater than 1,000. The data also showed that surface antigen loss varied by race and was consistently higher among Caucasians compared to Asians. So again, the take-home message is the same. The lower the end of treatment surface antigen level prior to withdrawal, the greater the likelihood of achieving surface antigen loss after stopping treatment. Next slide, please. So these here are the AASLD guideline recommendations regarding withdrawal of antiviral therapy among surface antigen positive patients. And to inform these recommendations, the AASLD conducted its own systematic review of 11 studies, including almost 2,000 patients. And based on this systematic review, the AASLD concluded that adult patients with E-negative chronic hepatitis B without cirrhosis and who are receiving maintenance nucleoside analog therapy should not discontinue treatment until surface antigen loss is achieved. And this was a conditional recommendation, and the certainty of the evidence was very low. And this recommendation was largely driven by the low rates of surface antigen loss that were observed in prospective studies, randomized controlled prospective studies, as well as the relatively high rates of virological rebound, ALT flares, and the high need for restarting antiviral therapy that was observed from cohort studies. Next slide, please. So although the AASLD takes a somewhat conservative viewpoint in terms of discontinuation of treatment, there are patients who do wish to discontinue treatment, and the guidelines provides criteria for stopping antiviral treatment. And notably, all these criteria must be met before an individual can be discontinued from therapy. I'll just quickly review these with you. There should be no history of advanced fibrosis, cirrhosis, hepatic decompensation, or cancer. If persons were E positive at the start of antiviral therapy, they should have undergone E seroconversion for at least 1 year and have an undetectable DNA that's maintained for at least 2 years. If the person was E antigen negative at the start of antiviral therapy, the duration of undetectable DNA should be a minimum of 2 years. There should be no co-infection with HIV or HDV, and importantly, AASLD does not recommend discontinuation of treatment in persons unless they have a quantitative surface antigen level less than 100. And of course, patients must be willing to adhere to frequent monitoring to look for virological rebound and ALT flares following withdrawal. Next slide, please. So on this slide, I've summarized a comparison of the recommendations from the 3 major liver societies as well as the WHO regarding withdrawal of antiviral therapy among surface antigen positive patients. And in general, AASLD and the WHO do not recommend discontinuing antiviral treatment, whereas EASL and APASL do recommend discontinuation of treatment in selected individuals. All the liver societies and the WHO agree on the criteria for who should discontinue treatment, and these are the absence of cirrhosis, undetectable DNA for a minimum of 2 to 3 years, and the patient should agree to close monitoring. And shown on the far right column, you can see that the end of treatment surface antigen level is an important predictor of who's going to achieve surface antigen loss, and therefore is an important criteria before considering treatment discontinuation in any patient, be they white or Asian. So while the guidelines might differ in their recommendation whether to stop treatment, there's largely good consensus on who should stop treatment. Next slide, please. So now I'd like to turn to the third part of my talk, which is the role of quantitative surface antigen testing in treatment decisions. And first, I'd like to highlight that surface antigen level is not a primary criterion for treatment initiation with current therapy, that is nucleotide analogues and peg interferon. However, surface antigen level is a key determinant in the selection of candidates for novel therapies, including small interfering RNAs, antisense oligonucleotides, and therapeutic vaccination, as you've heard from the prior speakers. Next slide, please. So you can see, I'd like to use bepirovirsen as an example to illustrate the point. And this is data from the phase 2 trial demonstrating that baseline surface antigen level has a significant impact on response to antisense oligonucleotides. And among patients receiving bepirovirsen, whether they were on background nucleoside analog treatment or not on nucleoside analog therapy, higher levels of surface antigen were associated with a lower response rate to bepirovirsen. On the left panel, you can see among patients on nucleoside analogs receiving bepirovirsen, those with lower surface antigen levels defined as less than 10 to the 3, the rate of functional cure was 22% compared to only 6% in those with levels greater than 10 to the 3. Similarly, among persons not on nucleoside analogs, similar findings were observed. Those with low levels had a response rate of 25% compared to only 7% of those with higher levels. So the key take-home message from this data is that lower surface antigen levels were associated with a 3 to 4-fold greater likelihood of experiencing S antigen loss, which is why surface antigen level of 3,000 was chosen as an eligibility criteria for the phase 3 study. Next slide, please. As you can see, this data has been presented by the other speakers, so I won't belabor the point other than to highlight again or reemphasize that baseline surface antigen level is an important predictor of response to antisense oligonucleotides and also for small interfering RNAs as well as therapeutic vaccines and for identification of patients who are more likely to benefit from this treatment. Next slide, please, and this is my last slide. So the key take-home messages are that quantitative surface antigen levels provide complementary information to HBV DNA, particularly E-negative persons, and should be monitored annually in untreated persons. It's the best predictor of surface antigen loss and improves HCC risk stratification in E-negative patients with viral levels less than 2,000. It has a limited role for routine quantitative monitoring during nucleoside analog therapy. And it's an important biomarker for selecting candidates for nuke withdrawal as well as candidates for emerging therapies. So thank you so much, and happy to take any questions, and apologies for the technical difficulties.
Thank you, Mark. Great, a great overview. There's several questions in the Q&A regarding differences in the quantity of HBsAg by genotype and whether some of the racial differences are actually genotype differences. And that's relevant to all the presentations, but just wanted to start with you and your thoughts about that.
Yeah, actually, it's a really good question, John, and I think whoever asked the question is onto something here because surface antigen levels do vary by genotype. They tend to be lower among persons with genotype A and B compared to those with genotype C and D, and that might account for some of the differences, but I don't think it accounts for all. I mean, obviously, if loss of surface antigen is in your definition of functional cure, obviously the lower that level is, then the more likely you are to achieve that. It's sort of predicting, the obvious.
Can I follow this answer?
Yes, please.
Yeah, because I have seen in the chat that Fumi has asked about African patients and genotype E. And there is information in African patients, not across different countries, only in selected countries. And it seems, and this is a work done by Maud Lemoine, that patients infected by genotype E, that is more frequent in Africa than in Europe, have high levels of HBs antigen. So as Mark has shown, there is difference in the levels depending on the genotype.
Thank you. Dr. Lim, if you're on, do you have any comments?
No, I have no other comments.
Okay. Thank you. There was also a question about, as you pointed out, Mark, and others actually, where, that the trend in the, changes in quantity of HBsAg is important. And so is that just something we have to learn with greater experience? Is like, how in clinical practice should you monitor those trends and which ones are really clinically meaningful? Or do you think there's already data to help clinicians assess those trends? I'll start with Mark, but others can come in.
Yeah, sure. I mean, I think as Dr. Booty showed you very nicely, levels of surface antigen do have important, clinical implications for managing patients. And the EASL guidelines came out and strongly recommended measuring levels at a minimum of at least once a year. Unfortunately, AASLD did not make that recommendation because that had more to do with availability of the test here in the US. We don't disagree with the EASL recommendations. And personally, if I had it available here, it's something that I would advocate measuring and would certainly obtain on my patients. Because I do think it is useful in terms of advising patients on what their chances are of spontaneous clearance of surface antigen. As I mentioned, it's not helpful in making the decision whether somebody should go on treatment or not. And then, as I showed some data, that monitoring it serially can provide valuable information in terms of one's risk for developing liver cancer. So I do think it's clinically useful, and I completely agree with monitoring this if it's available.
Thank you.
And I think it's very useful for patients, for explain how complex is hepatitis B for patients, because now we have all patients under treatment, virological suppressed with HBV DNA undetectable, and sometimes patients ask about stop treatment, how long has to be this treatment, and then using HBs antigen levels, you can explain better. You need to continue the treatment because you have very high levels of HBs antigen, and we stop treatment, there will be a rebound, a virological rebound, or you can say you are close to clearance of HBs antigen. So I think for the conversation with the patient, HBs antigen levels is very useful. And I can tell you that academic centers in Europe, we do every day in our patients.
Okay. Thank you. There was also a question about Delta. Obviously we're talking about quantitative HBsAg, but does it have any relevance to Delta replication and the changes in the response to Delta therapies? Again, I'll start with Mark and then go to Maria and Dr. Lim.
So we have less experience using surface antigen levels to monitor Delta patients here in the US. Maria will have more data. What I can say is that I do believe there is some data showing that the level of surface antigen is also predictive of response to some of these novel therapies in development for hepatitis D, not bulevirtide, the approved one, but the small interfering RNAs, where of course the higher the surface antigen level you start with, the less likely you will be to respond. Although these new therapies are very potent, and a majority, 80 to 90% of people can drop their surface antigen levels to below 100 and certainly even 10. The one point I will make before I turn over to Maria is what we've been learning from these new trials are that you can actually achieve Delta clearance without clearing surface antigen. And this is, I think, a paradigm shift that we hadn't appreciated before, that it's possible to lose HDV RNA without clearing surface antigen.
Thank you. Maria, please.
Yeah, we measure HBs antigen in patients with hepatitis Delta, but to be honest, the useful is very limited. So we don't take decisions based on HBs antigen levels. I think it's more for investigation. As you know, there are different isoforms of HBs, and there are some preliminary data suggesting that the changes or the proportion of these isoforms are different in patients with Delta from patients with hepatitis B. But for our clinical practice, we don't have a specific use different from hepatitis B in patients with Delta.
Thank you so much. Dr. Lim, any additional thoughts, please?
Actually, the Delta virus prevalence is extremely low in South Korea. So we don't have much experience for Delta and the association with HBs antigen.
Thank you. Thank you. Thank you all. We'll have hopefully have time for some more questions, but let's move on to the other speakers where we'll turn to the availability of quantitative hepatitis B surface antigen testing in the United States, and greatly appreciate representatives joining from commercial laboratories in the United States with us for our webinar today. Pleased to welcome Dr. Charles Walworth, who's the AVP for Medical Affairs and Education, Discipline Director, Infectious Molecular at LabCorp, and with his colleague, Dr. Laura Gillum, Medical Science Liaison and Discipline Director for Infectious Diseases at LabCorp. So Charles and Laura, over to you, please.
Thank you, and I'll go ahead and share our slides. And I have put them in presentation mode. Just let me know once you can see them. Going.
Looks good.
Perfect. So thank you for the opportunity. Great introduction to quantitative Hep B surface antigen testing. So there's a few slides I can go through pretty quickly. But I'm going to talk about testing, the availability of testing in our experience at LabCorp, just as a representative of a commercial laboratory. So we received a number of questions, so I'll go through Hep B surface antigen testing in the absence of an FDA licensed test, the availability and accessibility of testing, how we communicate results to clients, and how we're hearing clients or clinicians are integrating these results into clinical decision-making and patient management. Kind of our perspective on more sensitive or ultra-sensitive Hep B surface antigen assays, and then what we've seen as far as ordering in the United States and the reimbursement landscape. So LabCorp, along with other laboratories, does offer quantitative Hep B surface antigen testing. We've offered it since about 2019. And ours is a laboratory-developed test in the absence of an FDA-cleared assay. Our LDT was designed and validated by Jeff Sperindi in our Monogram Biosciences laboratory. So these are experienced lab scientists who've developed the assay in compliance with CLIA and New York State regulatory requirements. As I mentioned, it is an in-house developed LDT. It does utilize some components of the diasorin assay, but is largely lab developed. It does include multiple quantitative controls that were formulated at Monogram Biosciences using recombinant Hep B surface antigen, and it's been calibrated to a WHO reference standard. Since it is quantitative, we always include a calibration curve, and in this case, we have a 7-point calibration curve and a reportable quantitative range of 0.02 to 25,000 international units per mil. As far as availability, this test is available just like a standard CBC or any other hepatitis testing. It's available for clinician ordering via the EMR or EHR and an online portal. It's published online in a directory of services, and it is available nationally. I've shown you a snapshot here, a screenshot of the test menu. The test name is Hep B surface antigen quantitative, monitor. I think we certainly experienced some challenges with clinicians incorrectly ordering this test, thinking that it was a qualitative screen and trying to use this to diagnose infection. So we've really had to tweak the name of the test, and you'll see some of the comments we've had to add, as well as use statements to try to ensure that we have appropriate use of the test. Results are reported back, again, just by standard mechanisms, same as we report back any other test. So electronically through the EMR and EHR, we do have a results portal, and we do have those clinicians who stick to fax and paper reports. Hopefully we can reduce those. But what I'm showing you on the right is a screenshot of a sample report. This is what it would look like in our system. Certainly as it goes through a medical into an EMR, it can change the look. But basically you're seeing the name of the test, the Hep B surface antigen, a result. So in this case, it's 56.25 international units per mil. And then we include a comment about the quantitative range. And then you see I have the comment there too about the intended use. Again, to try to reduce the number of individuals ordering the quantitative test when they're really looking to diagnose or to screen. And then as far as clinician support, certainly there are always questions around testing and utilization. So as I showed you previously, we do have our general interpretive comments on the reports. On our website and directory of service, we have additional information, and I'm showing you a screenshot to the right, where we include the methodology being used, the intended use, the limitations of the assay, and then there are some additional links to try to help support. And then finally, certainly we have medical science liaisons like myself and other representatives who are available to consult with clinicians as needed. This was well covered by the three previous speakers. Just the utilization of Hep B, the quant assay, certainly has evolved from a research biomarker into a more clinically actionable tool, along with the other markers, the Hep B DNA, ALT, and other serology. And I've just listed here what you've already heard. Utilization of the test to define disease phase and risk stratification, to assess disease activity and progression, to guide treatment, to monitor treatment response and inform early discontinuation, to predict endpoints and functional cure, to support post-treatment monitoring and assess for the risk of reactivation. And then obviously now at the forefront to determine eligibility for emerging therapies. We certainly expect increase in demand with the availability of therapeutics. So as far as the question to our thoughts on a more sensitive or ultra-sensitive quant Hep B surface antigen, as I mentioned, our lower limit of quantitation is 0.02 international units per mil. Certainly, more sensitive assays could improve the confidence in treatment endpoints, could help refine thresholds for treatment discontinuation, and may aid in identifying more individuals eligible for treatment. But as all the other speakers have said, I think more studies are really needed to determine the added value of lower limits of detection. And then we would just throw in certainly the addition of other biomarkers to provide biological insight into what that Hep B surface antigen means would be of great value. And in the US, looking for more standardized assays for Hep B RNA and Hep B core-related antigen. So as far as utilization and reimbursement at LabCorp, and this is going to be unique to LabCorp based on our population. In 2025, we had more than 10,000 orders for quantitative Hep B surface antigen. That volume has increased year over year since the assay was launched in 2019, and we certainly anticipate that volume increasing significantly with new therapeutics being available. Based on LabCorp data, we have found that the assay is reimbursed by insurance with more than 90% coverage, which is fantastic. But again, that is unique to LabCorp data, and we don't know if that's representative of what other labs may see based on their population. So in summary, it's been well discussed already. We do feel the quant Hep B surface antigen enhances management of hepatitis B by informing risk, supporting treatment decisions and outcomes predictions, and certainly now in the eligibility for treatment. So appreciate the opportunity to discuss and look forward to hearing from the other speakers. Thank you.
Thank you so much. Excellent overview. Really appreciate it. Let's go ahead and turn it over to Quest Diagnostics, since this is both presentations are relevant to the availability of the test. If you can go to slideshow option, there we go. And we're here to talk to hear from J.R. Caldera, Associate Science Director in R&D for Infectious Diseases at Quest Diagnostics. J.R., over to you.
Yes, good morning. Thank you so much for the invitation. And I do apologize, my internet's a little glitchy, so I will be turning off my video for this part just to make sure that we're covered. But if you can let me know if you're seeing the right view, that would be great.
We were seeing, there we are. We're seeing presentation view at the moment.
How does this work?
We're seeing your next slide. So if you...
Is this good?
That's good. Yes. Go ahead, please.
Perfect.
Thank you.
Perfect. Thank you again. Again, I'm Jared Caldera. I'm the Associate Scientific Director here at Quest, specifically in the San Juan Capistrano campus. So I am in California. Very similar to what my colleagues in LabCorp presented, we do offer quantitative testing. So I will be echoing quite a bit of what they've talked about, but different approach to their testing. Our testing is a much simpler route. We basically modified what we already offer as a qualitative test using the OrthoVitros that's been FDA cleared for qualitative assessment of surface antigen. And effectively, what we did was take the exact same chemistry, which is an immunometric chemistry that you see here, using a capture antibody to capture the surface antigen and using a detection antibody that then produces a signal that's quite linear, at least within the linearity, to be able to produce a quantitative measurement using a standard that we've implemented in-house. So by the addition of a standard, we're able to quantitate that light signal that's being produced by the instrument into a quantitative value. We did validate it according to CLIA standards, of course, because we are a CLIA lab. And in those assessments, we included linearity, accuracy, precision, reference range, but importantly, genotypic coverage, and in terms of the robustness and what our assay can detect in terms of different HBV genotypes. And the validation materials are all listed here. Just to overview of the data, just so we can share a little bit of that validation study. In our assessment, the linearity of the OrthoVitros, we determined to measure linearly between a value of 0.05 all the way to 250. So very similar lower limit of quantitation to our LabCorp colleagues, ending at 250 IU per ml, but we do perform both undiluted and a 1:100 dilution, and that's what allows us to reach a upper threshold of reporting all the way to 25,000. In terms of accuracy, it's no surprise, it's 100% qualitative agreement, and that's a very simple measurement for us in terms of based on previously characterized sample, if they were previously measured, this assay also measured it, and then if they were negative, they were negative. But I think a more important metric for quantitative measurements are really the regression analysis that I'm showing here, both the R-squared and the slope, which we can appreciate here is quite impeccably close to 1, just showing the integrity of our assay. The precision is again quite good, both the intra and inter-precision, both less than 10%. And reference range verification, we did this using blood donor samples, which we presume to be otherwise healthy, and there was 100% non-detection of surface antigen in that population. In terms of genotypic coverage, I think is one of the things that came up as a question earlier. We did extensively try to validate the coverage of our assay in terms of the different genotypes that are present. Of course, with Quest being a US-based, but have clients internationally, we needed to be able to make sure that our assay will work for our clients globally. We did that using both a panel that's available through WHO that includes these genotypes, as well as samples that were submitted to Quest for our separate HBV genotyping assay. So as you can see here, we have coverage all through all the genotypes listed here, as well as some that we included as escape mutants that we detected using our genotype assay. So for genotypes A, B, C, and G, we had access to what we consider escape mutants that had a mutation in a G145 position. And in our assay, all of those were also detected in terms of the surface antigen in that sample. Similar to LabCorp, we do make it a very, very important point to distinguish this from diagnostic testing. I think we share a lot of the challenges in terms of having such a diverse breadth of menu offering that we need to make sure that our clinician colleagues are ordering the right tests. So we do make a point that in our test code and our test name, we include that it's for monitoring, specifically not for diagnosis. This is a test that's unrestricted. Our clinician colleagues and our clients are able to order this without restriction. And the report is shown here where it's, I consider it to be sort of straightforward and self-explanatory. We include the value with the units, and we do include an alert when it is a detectable and measurable quantity, as well as some guidelines in terms of the interpretation, again, highlighting that this is not intended for diagnosis, but rather for monitoring of patients with a previous diagnosis. And this is just some snippets from guidelines to discuss the potential utility of our assay. Dr. Gani and others have already discussed this, but I wanted to include this more to look at where the guidelines are mentioning the use of quantitative measurements for surface antigen and what values they're using in terms of clinical decision making, just to sort of demonstrate the sufficiency of our assay to be able to meet the requirements of those guidelines. So there were mentions that there are going to be assays in the future that are categorically ultrasensitive, going as low detection as 0.005. Although we are not quite there yet, I will iterate that in terms of our clinically reportable range, it is sufficient to be able to comply at least with the requirements of those guidelines as high as going to 25,000 IU per ml. We do have quite a bit of resources that are available in our Quest website. These are clickable links. Unfortunately, you won't be able to click them as I am sharing them now, but if you have any need to look into our resources, you can just Google our Quest test menu and look up our test, and you should be able to click through all the different resources that we have available, including a clinical focus, not just for hepatitis B, but for our viral hepatitis, including all the different tests that we offer for that disease group, and an FAQ, again, just to answer some of the most frequently asked questions regarding our quantitative testing for monitoring. With that, I'm going to stop and thank you all for your attention. I will be happy to answer a question afterwards.
Thank you so much. It's a great overview, JR. Greatly appreciate it. Just in the interest of time, let's move it over before we go into Q&A over to our colleague Alex Greninger, who's done an analytical performance comparing 3 quantitative surface antigen assays. Alex, over to you.
There you go. Can you hear me? All right. Thanks, Dr.
Yes.
Ward. And everyone, really appreciate the opportunity to present in this webinar on this really important issue. I feel like I'm presenting the baking soda volcano here at the Westinghouse Talent Fair a bit when you follow our South Korean and European colleagues. But we're going to be talking about some assays that are the pride of 2010 to 2014. We compared 3 different quantitative hepatitis B surface antigen assays here at the University of Washington. And so much of this is due to the fact that we do not have FDA authorized testing available in the United States. So these are challenging assays to bring on. I'm going to show conflicts first. We do a variety of work with diagnostic test manufacturers as well as antiviral manufacturers. All this goes to the University of Washington. I am married to LabCorp, but Chuck and Laura will tell you that that does not prevent me from giving them grief once in a while. And I work at the University of Washington, so that is its own sort of conflict in itself. All right. So this started basically back in 2019. When I became a protocol virologist for the ACTG hepatitis. We had some hepatitis B trials come on, and we had previously performed a lot of testing for the hepatitis B research network for the NIH, but we wanted to reevaluate the current situation of assays that were available. There's more automation, more platforms that come out. And again, there is no FDA authorized quantitative hepatitis B surface antigen available in these United States of America. Laura and JR both discussed, the approaches, the laboratory developed test approaches that they had to take to make assays available, which is phenomenal. And I want to also say that what I'm discussing here is different than the tests that they're running because they did their own validations, and that's one of the challenges when it comes to laboratory developed tests. Here, when we looked at these tests, we were basically running them for the most part as they come out of the box. And we looked specifically at the Roche Lexis hepatitis B surface antigen 2 Quant 2 assay, available again in the early 2010s, the Liaison hepatitis B surface antigen Quant assay, and as well as the Architect qualitative assays. You can't have 2 Supreme Court justices. You got to have a third one to sort of break ties. So we needed to bring in a third assay. And when we started this was before those ultra-sensitive assays were available. So we used the existing qualitative assay that we use currently in our lab, and it worked pretty well as a quantitative assay. So we did a full quantitative validation on it. And so we're comparing these particular tests. I will say that when you do this, you have to work with the groups to basically import their reagent, have it remarked as RUO agent. It's a big bear. It is not necessarily easy to do this work I think maybe I can offer some of the like, sort of behind the scenes aspects here, doing this type of testing. And I apologize in advance. It's going to be a table friendly. The clinical chemists are going to be happy. Everyone else won't be. We're doing a lot of tables today. All right, so the first thing we looked at was just accuracy across different WHO international standards. And so the third international standard came out, I think, in 2014, which is the current standard. It's this 12/226. And after you recalibrate the liaison, well, the architect and the Alexis were both worked pretty well against this value. You see very different of 47.3 to 46.5, 43.4 to 47. Liaison's a little bit higher at 56, but these work pretty well. And then there's another panel that is the second international standard that's diluted, and this is usually used for determining aspects of limits of quant. And we had pretty good agreement with the second international standard, which is what the liaison is calibrated to. So that was good out of the gates. These assays work relatively well in this accuracy standpoint. Where we started to see some differences was when we started diluting down the third international standard to look at variance and really test those limits of quant. To see the claimed limits of quant. So we actually saw a really good limit of quant on our architect assay. We call it 0.02 IUs per mil. We're doing that based on a total error calculation and looking at the percent total error from a root mean square standpoint of less than 30%. The Alexis, it's hard because it doesn't return a value less than 0.05 because that's its claimed analytical lower limit of quant, so it doesn't return a value, so it's really hard to verify below that level, but it basically confirmed around the level that you would expect for it. With the liaison, we saw a number of values that were greater than 30%, and so we actually claimed a much higher, or confirmed a much higher limit of quant here at around 1 IUs per mil. These are subtly above 30, so you could see something that's higher than that. But with the liaison, we always saw this sort of like a limited linearity that we found in our hands, especially with the third WHO international standard, that caused it to have a very, very tight sort of linear range that we had to dilute into each time. And so that was sort of a limitation of that assay. If you just take 72 samples that were qualitatively positive on our existing assays and compare them, this is where the assays do quite well. After you've done the calibration and you dilute into those linear ranges, this is how you would run them clinically. And this gives us great confidence. Here we're comparing the architect and the Alexis and the liaison, and the architect and the liaison across values. You can see a very, very high correlation, good slopes on these values. And this is to look at the geometric mean difference between these assays. And you can see they're, for the most part, pretty close to that, right at the zero equivalence between the assays. So once you've gone through the trouble of calibrating the assays, running them as they're being run in the reference labs, I'm sure as well, this works out well for the values. You just have to do all the front matter to figure out, what is the appropriate linear range that you can do. So that was positive. And then we got to another area that we like to highlight here is some lot-to-lot reagent variability that we've seen as we pulled in different lots of reagents, specifically on the liaison. Now, a big limitation here is we did not evaluate. We were able to run all the Roche testing in a single lot, so we did not look at that in the Roche. So I can't say that there's not the same thing. But I'm going to highlight right here in this table. If you take that third WHO international standard that comes in at 47.3, and you run it from one lot, recalibrate, run to the next slot, recalibrate, run to the next slot, run to the next slot, you're seeing that move of that value from 56 to 91 to 75 to 91. And so you're seeing a reasonably high lot-to-lot difference at that third international standard. Now, on the calibrators for the second international standard that's diluted, you see a much limited lot-to-lot variation. And we saw a little bit on the architect, but this was more of an issue we've seen with our testing on the liaison. So we wanted to call that out. And that's a short talk, so that's basically what I'm presenting on this information. So we think that these assays overall show acceptable precision and accuracy. You just have to recalibrate the liaison from the second international standard to the third. We do have some challenges with the linearity, lower limit of quant, and lot-to-lot variability with the liaison. And I'll just say, if we put our nickel down, I think this is helpful when we say, well, if we were to run on these assays, we would just go with the Roche Quant2 assay. But all this is really affected by the FDA authorization of these tests for many labs to be able to have more widespread implementation of this testing. So a few thoughts here and limitations. I talked about how the Alexis does not return results below a 0.05, so you can't really claim an LLOQ below that, and we didn't look at lot-to-lot variability. We validated the qualitative assay as a quantitative assay and didn't look at some of those higher better LLOQ, claimed LLOQs like the Abbott or the Fujiri Bio that Dr. Lim called out, which are very interesting. But I always find it interesting how we're chasing that lower limit of quant, but here in the other world, we have a calibrator for the WHO. And I think this is helpful for our clinical colleagues to call this out. You look at all the new agent trials, you looked at the risk stratification, and we're all talking about, mostly talking about values up in the thousands of IU per mil. The WHO calibrator, the top calibrator only goes to 47. So we're always talking about doing lots of dilutions to get into, or we're often talking about doing dilutions, except for I appreciate LabCorp's 7-point calibrator curve to get other material. You really have to bring in other material unless if you want to rely on that WHO, it only goes up to 47 IUs per mil. And finally, I'm really excited by the new trial from GSK. We have so many new drugs that are going to come out here. So I just wanted to finish and say, if the USA can score 4 goals in a World Cup game, it's 2026. It is time. It is time for us to get an FDA-authorized quantitative hepatitis B surface antigen. I look forward for manufacturers having a reason and not having this sort of vicious cycle where there's no indication, it's not in the guidelines, it's costly to go to the FDA, so we're not going to bring it forward. We're starting to sort of write that circle, and this is a great time for this webinar. With that, I'd like to give a huge shout out to our visiting scientist, Young-Jin Ko, Dr. Lim, I hope you look for, which comes back to South Korea in a month or two. Done a phenomenal job on this work, as well as John Reed. This was a recent paper in clinical chemistry. And with that, happy to take any questions. And huge thanks to Dr. Ward and the whole team for putting this webinar together at this really important time.
Thank you. Excellent. And I'm glad you put in your reference so that others can go and read in more detail your evaluation. Excellent job. Excellent. I agree. If by all means, if the U.S. can score 4 goals in the World Cup, certainly we should be able to get some FDA-approved tests. I know we only have time for 1 or 2 questions. I did just want to give the laboratorians on the call, Jo or Laura and Charles. I don't know if you have any comments on Alex's evaluation. I'll stop there just for your comments.
Just a real quick comment regarding, we were under tremendous pressure. Clinicians sometimes are ahead of what the guidelines recommend, and we were under tremendous pressure to get an assay out there to the point where we even had several accounts, high-profile accounts, that said, you either get an assay out there or we're leaving LabCorp. I mean, there was that much of an interest in moving forward with this. So that's just, we've seen this in HIV where sometimes the clinical management is ahead of what guideline recommendations are, and we definitely have seen this in this area here.
Thank you. But the other point that's come up in the Q&A quickly is, what's the difference between CLIA approved and FDA approved, and how does that improve access? For me, I believe it just improves the access because the individual laboratories don't have to go through that testing that both you and Quest put together. But if you just can briefly describe that difference for persons on the webinar. Charles, maybe you can take a crack at that.
I'm sorry, my audio went out while you were.
Oh, yeah, just the difference. If you were trying to get some explanation of what's the difference between CLIA approved and FDA approved.
We always feel that when you've got that FDA approval, it seems to add some additional leverage to the confidence in what the clinicians are ordering. That's for sure. But by and large, if there is only sometimes that's not available, and therefore we see it not make a big difference in the utilization. But with respect to an FDA approval, it definitely gives much greater leverage to what we offer out there.
Okay. And please start filling out the evaluation poll. The very last question. I know for Abbott and for Roche, of the the same platform is used for qualitative HBsAg as it is for quantitative. But for LabCorp and Quest, what platform, may I ask, are you using for your HBsAg quantitative testing? Is it totally a separate platform that you've created, or are you using some of your existing, platforms? Because I can imagine you're using some of those, maybe a DiaSorin platform in your case.
Yeah, so at LabCorp, we are not using the liaison. We're using a separate instrument.
Okay.
Again, just validated using some of their reagents, but it's a separate instrument.
Thank you.
For Quest, we are using the exact same instrument that we use for qualitative measurements. So we are using the Orthos Vitros. And what we do is we implement an 8-point standard to be able to translate the result into a quantitative value.
Excellent. Well, excellent. I certainly learned a lot over the last 90 minutes, thanks to all of you. And I believe our webinar participants who attended did so as well. So thank you again so much for a very timely webinar, as we're on the cusp of a functional cure era for hepatitis B here in the US and around the world. And we're going to continue to learn together how to use these tests and the other ones that Laura put out and Dr. Lim put out in particular as additional ones to consider. So again, please fill out the evaluation poll. Go to our webinar section of our website, globalhep.org. And this video will be up in short order together with the slides, and look forward to continuing to work with all of you to improve testing and advance our progress toward elimination of hepatitis B around the world. Thank you again. Bye-bye. Thank you.
Thank you.
Thank you again. Great job, everyone.